and welcome to Microbial Musings, a miniseries podcast on infection prevention. The Arizona chapter of American Academy of Pediatrics is proud to partner with the American Academy of Pediatrics and the Centers for Disease Control and Prevention's Project First Line to bring you this podcast miniseries. I'm Dr. Helene Felman, general pediatrician, member of the Arizona AAP chapter, one of their Project First Line ambassadors, and a member of the chapter's advocacy committee. I do have a financial disclosure as I'm the principal investigator of an Access-sponsored grant to study an AI tool to help diagnose autism. We hope you enjoy this podcast miniseries. Good day, everybody. This is Dr. Helene Felman here again with Microbial Musings. Today, I have the honor and pleasure of getting a chance to talk about RSV, or respiratory syncytial virus, with one of my colleagues, Dr. Nicole King, who is a general pediatrician within our division, assistant professor of pediatrics, and a proud member of the Arizona AAP chapter. Welcome, Dr. King.
Thank you so much. I'm so excited to get to talk to you today about RSV.
Excellent. So let's just get started. What are some clinical features of RSV?
Yeah, so I love to kind of paint the picture of the typical RSV patient where we might be seeing them in clinic or even in the emergency department, coming in with increased workup breathing and maybe even some noisy breathing, and the parent just thinks that they're not doing super well. My favorite thing to bring up is this idea of the changing exam. So oftentimes when we send in our residents to go take a listen and evaluate the child, they may come out and present to us as attendings and say one thing, and then we go in and check in on the child and we hear something completely different. Yeah. That's a really common feature, I think, this changing exam. Certainly we can see some increased workup breathing, some retractions, some noisy breathing, or even like a washing machine type of sound when we auscultate. And then we can also hear some wheezing, typically not focal breath sounds though, and often there's not any fever, or if there is a fever, it's a low-grade fever. Also, copious nasal secretions is definitely a large component of this illness.
Yeah. So thanks for that.
Yeah.
I completely agree. I feel like most of the time I'm hearing that kind of washing machine sound. Mm-hmm. And that's definitely one of the things to look out for when you're evaluating a child for potential RSV.
Yeah. Tell us a little bit about some of the treatment options that we have for RSV.
Yeah, we've got, fortunately, a lot on our plate now, which is different than in years past. So we have, I guess maybe not treatments, but definitely for prevention. Mm-hmm. So treatment options, let's start with that. Unfortunately, it's mostly supportive care. So it's giving a child oxygen if they need oxygen, and providing suctioning if they need help with those nasal secretions, which tend to be super kind of thick and just copious. So that is kind of what we see in terms of the clinical presentation and the treatment options. Like I said, unfortunately, not great for treatment, but we do have some more prevention strategies, which we're going to talk about in a little bit. I know that when I'm seeing a kid in clinic and they're really not looking great, but saturating well on oxygen, I tend to bring them back really frequently. But the other thing to keep in mind is that because of the lower respiratory illness process that happens with RSV, those children sometimes can have slightly lower oxygen levels, and to be kind of a little bit more comfortable on the lower end of the 90s, and only consider hospitalization if you're dipping below 92% or even 90%. Some clinicians will just watch kids very carefully. You can try some bronchodilators, although not super effective, and the data and the evidence not always strong. It depends on the clinical scenario. So really just supportive care. Yeah. And oxygen and hospitalization is needed for those low oxygen levels.
For sure. And I also think if you are going to give a bronchodilator, it's really important to get that pre and post exam too.
Absolutely.
So, yeah. Great.
Okay. And then with that, we're talking about hospitalization. What do you think increases the risk of hospitalization for those kids that we see with RSV?
Yeah, so I think specifically it's the age range that we pay very close attention to, which ties into our recommendations for who we give preventative treatments to as well. So typically, I think the highest risk infants, especially term infants who don't have any medical complications, are at highest risk when they're between about 4 weeks of age all the way up to 8 months or so. And so we do know that it's the highest cause for hospitalization of infants under the age of 1 year in the United States. And so certainly those children are at risk in that age range. There may be some passive maternal antibody protection in those first 4 weeks, which is why oftentimes we don't see as high hospitalization rates in those very young infants or neonates, just if mom happened to be exposed while baby was still in utero. But once you hit that 4-week mark, that seems to wane. That passive immunity seems to wane. And, these children have never been exposed to RSV, and they still have a developing immune system, which puts them at higher risk. And they have a hard time with clearing their nasal secretions by themselves and being able to breathe and eat at the same time. It can be a real struggle.
Yeah.
So, we talked a lot about what RSV looks like and how to identify it, but what makes you think about something else might be going on besides RSV when you see these kids?
Yeah, that's a great question. I feel like, as we talked about earlier, a lot of children who present with RSV don't always have high fevers. So high fever, like over 102, 103, makes me think that there's some other bacterial process going on, that it's not just a virus. Any focalities on exam. So as we talked about with the lung exam that we see mostly with RSV, it's very coarse and not focal. But if you're hearing something, either the absence of breath sounds or crackles or coarser breath sounds in one area compared to another, and not just that changing exam that we talked about, that makes me think that there's something else going on. Clearly, you should try to look in their ears too. Sometimes you see otitis media with RSV, but I think the most classic and common co-infection that you see with RSV is a urinary tract infection. And so if you're having a fever in someone who's very high with RSV, consider getting a urinalysis, even though I think for a lot of these little ones that may mean a catheterized specimen, which is not an easy procedure to complete in any situation, in any circumstance, in any location, be it outpatient or inpatient, but it is something to consider. So
totally. Yeah. And then, of course, if we're seeing a fever in a neonate, we would do the whole shebang. But,
right.
I think those are some really great things to think about when we're seeing these kids.
Absolutely. Yeah. And then with that, we've talked, I think, a lot about clinical features, treatment options, what to worry about besides RSV in those kids with RSV. What sorts of precautions are recommended when a kid presents either to your office or the hospital for RSV?
Yeah, this is an interesting one that I recently learned. We are supposed to do contact precautions for children with known RSV. So it turns out that kids who have RSV really don't have enough droplets that they create to require droplet precautions. And so it might have something to do with the fact that it's actually a lower respiratory tract infection. And so really it's in the secretions that children will make as a part of the illness, but that only requires your contact precautions.
Yeah, that was interesting to learn too. That was part of my podcast that I did with Dr. Price, and just reviewing that, surprised me a little bit as well. Yeah. I think in the outpatient setting, when you're not sure if it's RSV or flu, I think better safe than sorry to put on those droplet precautions and wear a mask and be a little bit more careful. But if you know it's RSV, I think you can be safe to just put on your gloves and wear a gown and protect yourself. So
yeah, I agree. I tend to, if I have a child with respiratory or rhinitis type of complaints, I will always wear a mask going into the room, and even consider wearing an N95 just in case it might be COVID, because that's still around too. But if you have a confirmed case, all we need is the contact precautions.
Yeah, that was interesting for sure.
Okay, so what are some of our prevention strategies to stop RSV before we develop the infection?
Yeah, and this is kind of what I alluded to a little bit earlier, that this year in particular, this season, we've had 2 additional preventative strategies for RSV that have not been around prior. So I think, in years past, decades past, we started with palivizumab, which is the brand name goes by Synagis. So that has been in our arsenal for a while now. But this year, the new kids on the block are niracivimab and Abrysvo. So nirsevimab is very similar to palivizumab in that it is an antibody treatment. However, nirsevimab, which is also known, the brand name is Beyfortus, that attacks the same part of the RSV protein. However, it provides additional coverage in that the antibody coverage lasts longer than palivizumab. So palivizumab, as many of you pediatricians know, it is a monthly injection throughout the season of RSV, only recommended for our highest risk infants because it wasn't super effective at preventing hospitalization unless it was given every single month. And so it was only recommended in our highest risk infants, so those that are premature or with chronic heart disease, lung disease, or those that are immunocompromised. Nirsevimab, on the other hand, because it lasts a little bit longer, so one injection covers an infant the entire season, it's actually recommended for kids birth through age 8 months within that RSV season. So we'll talk a little bit about the timing of that with the next question. However, just to touch upon Abrysvo, which is a new RSV vaccine that's been approved not for the infants, but for pregnant mothers to be given in that last trimester of pregnancy right before they deliver birth. And it counts as long as it's given 2 weeks before delivery. So this year, moms, expectant mothers, were offered that vaccination, and that was also very helpful preventing RSV infection. And so I guess to tie that all together, Dr. King, what's the best timeline in terms of administering these vaccinations?
Yeah, I think that it's really important to think about the timeline as trying to do this medication before the potential for any exposure within the season. And so our typical season for RSV is usually around October to March. However, sometimes there can be differences depending on what's going on in the world and depending on your individual region too. So, we definitely have given this injection to infants right after they're born or when they're entering their first season within that age range of birth to 8 months. But tell us a little bit more about the typical season and how that compares to national trends or Arizona specifically, and how did COVID impact?
Yeah, COVID just, as we all know, threw a wrench in everything. So I'll start perhaps talking a little bit about the typical seasons pre-COVID. So pre-COVID, traditionally it follows that kind of October to March trends, where that is when we see the highest incidence of RSV or respiratory syncytial virus, both in the country and in our state. That said, in Arizona specifically and points westward, we tend to present with RSV slightly later than our East Coast colleagues and Southern colleagues. So those seasons tend to be a little bit earlier versus our predicted seasons, which tend to be a little later. And so to talk a little bit about COVID, so in 2020, there was really no RSV. There was a little bit right before we went into lockdown. However, did not see the same sort of numbers throughout the entire year because we were all inside. And as we talked about earlier, RSV is contact. So if we're not seeing each other and we're not touching one another, we're not sharing those germs. And so we're not spreading RSV. So it shouldn't be that surprising. What was surprising is that the year after, when things started opening up, the timing of our RSV season was just super wonky, for lack of a better term. So we saw a spike in the summer of 2021, which we'd never seen RSV then. There were many of us who were advocating for having access to palivizumab because we didn't have Beyfortus or nirsevimab yet. So we were giving Synagis or palivizumab a little bit earlier in the season than we had ever given before. And then the next 2 seasons have been a little bit odd as well, in that they've been a little bit earlier than prior seasons. And that has kind of borne out in the state of Arizona as well as nationally. But I thought it was really fascinating that when looking at our state's rates versus the national trends, that we present typically a little bit later here in Arizona than we do in other parts of the country. So that was fascinating to me.
Yeah. So it sounds like things had kind of gone through a hard reset over the COVID period, and now we're getting sort of back to the typical trends.
Yeah, but we'll see. Who knows? As you mentioned earlier, like COVID is still out there. It's definitely a little different than it was at the beginning. Interestingly, with Dr. Price yesterday, talking to him about precautions, it's up for debate whether or not all forms of COVID are true airborne infections. So I think he gave the advice, like, if you're concerned, always welcome to like wear your mask, but you never know what's going to change and how viruses are going to change with time. So it'll be interesting to see what the future holds. And my hope is that with supply chain issues being solved in this coming season for 2024 to 2025, that we'll be able to offer a lot of these preventative treatments and strategies like Abruzvo and Nirsevimab and Beyfortus. And so that may hopefully also change our landscape and the timing of these infections. Yeah.
We'll see what the future holds.
Yeah.
I would encourage everybody to take a look at the trends and the graphs that maybe we'll have linked in the podcast.
Yeah, we can see, definitely we'll try to include that link, but the Arizona Department of Health has some really fascinating charts based on the seasons. And so I encourage you all to take a look at that for RSV in particular between, I think as far back as 2015 to this season. It spans over 10 years and it's interesting to see the color maps. Yeah. I'll definitely try to include that link within the comments. And if we can't, just take a look yourself. So, wow. So we've covered a lot. We do have just a few more minutes left. I don't know if you have anything else that you wanted to share about your experiences with RSV, and then I can share a little bit about the vaccine efficacy too, but just leaving it up to you.
I just wanted to share my experience with talking to new families.
Oh, yes.
When it comes to the Abruzvo or the RSV vaccine.
Yeah.
It's really exciting that we can offer this to pregnant individuals who are interested in giving this passive immunity to their infant, and I think the best benefit of that and encouraging our pregnant individuals to get this treatment option is that then baby doesn't need an additional shot.
Yeah.
Once they're born. So I think that that's a really exciting option, and having the opportunity to promote that practice with our new parents has been a really special kind of experience.
Yeah. I think Dr. King gives an online kind of virtual introduction for some of our expectant mothers, and so that it's nice to be able to share something preventative that we can do and offer, because it's nice to have a tool in place to help your child without having to give that child another injection, which for some families is hard. I feel like for others it's perhaps not as hard. Thank you for sharing that.
I have another question for you, actually.
Sure.
I wonder if you've encountered this in your practice. I've had some parents be hesitant about giving the Nirsevimab injection because of the potential for fever, especially if it's given within that first month of life when a fever would mean a larger workup.
Yeah.
How have you encountered that, and how do you deal with it?
Yeah, I have had that question come up a few times when we were offering the Nirsevimab here in our office. And it's tough because we don't want to ignore a fever. However, in my experience, I have not encountered an infant that has had a fever after receiving the injection. And so even though it is one of the things that we counsel on when we give all vaccinations or injections, including Nirsevimab or Beyfortus, I still think that the risks of getting RSV and becoming hospitalized are higher than the risks of a fever. And now we have, fortunately, some other tools in place to help us evaluate the risk of a serious bacterial infection. You know, when I was training, everybody with a fever got the whole shebang, which included blood and urine and a spinal tap. I mean, nowadays, fortunately, with some additional blood markers, we don't always have to do that spinal tap, which I feel like gives me more confidence in offering this vaccine. And I can confidently say that the risks of giving this injection are much less than the risks of a potential fever, because that risk in and of itself is very low.
Yeah.
So it's a great question.
Yeah, I completely agree. I haven't actually seen any fevers that were attributable to the Nirsevimab injection, but I have had parents ask the question.
Yeah.
So I was curious. You can tell us a little bit about the efficacy or what's the impact of Nirsevimab?
Yeah, so Nirsevimab has some really great data thus far, looking at its efficacy in terms of medically attended RSV infection. It reduces that risk significantly. It also significantly reduces hospital admissions and those infants with very severe RSV, which is not a surprise. That's the goal. What was surprising is that nirocivimab also reduces antibiotic prescriptions, which we don't typically give for our infants with RSV. But as we talked about initially, you can have another infection, another bacterial infection. And so hopefully the vaccine also prevents those more serious bacterial infections that sometimes can come along with RSV along for the ride. Well, with that, I think we're about at time, but thank you so much, Dr. King, for joining me today to have this excellent discussion about RSV. And yeah.
Thank you for having me.